right, I'm ready.
Natty Light, thank you so much for being here. I actually put like a lot of work into this, and so I really do appreciate you being here. And for you listeners at home or on our really popular YouTube channel, thank you for tuning in. We are going to talk about CT surgery for the ABSITE. So Dr. Percival initially, you haven't met Dr. Percival yet. Dr. Percival initially made these slides, and then Dr. Nissen edited them. They are both very intelligent cardiothoracic surgeons right now. And so there was a lot that you'll see in the other surgery time video that is like really good for you to learn for your life for CT. But for this presentation and like for what you need to know for the ABSITE, that stuff is really not relevant. So I tried to make it more relevant, which is a little bit maybe more boring, but this is hopefully stuff that you'll actually see. So you'll see some of the slides are green and some of them are white. The white slides are like Dr. Nissen's slides that I kept in because I think that they're interesting or cool or whatever, but the green slides are stuff that I really think that you should know for the ABSITE. So what vein does the azygous vein drain into? The SVC. Yeah. So this is just like some general anatomy stuff. And so in terms of anterior, posterior, we have the phrenic and the vagus. Which one is going to be anterior? Yes, right? Because your phrenic is going to be on top of your pericardium. And that's when we're doing a like ED thoracotomy. That's what we're trying to avoid injuring, right? But the vagus is going to be posterior. And that's going to be like, we associate that with the carotid sheath, right? So think posterior for the vagus and anterior for the phrenic. What do type 1 pneumocytes do? What are their function? Just like the regular function. Yeah. Exactly. So the type 1 pneumocytes, there are more people here than just Natty Light for those of you listening. So, like if people get the questions wrong, like it's not just her. So the type 1 pneumocytes are the ones that participate in gas exchange, and the type 2 pneumocytes are the ones that make surfactant. And then the path of the thoracic duct is something that people talk about a lot. And I don't know why, but I have historically found this hard to think about. So I found this cute video on the internet. Oh, do you want to do it?
No.
Do
I
it.
was gonna say crosses at 245, but you already put it up on.
Sorry. Joe knew the answer to that. Joe knew that the thoracic duct crosses at T4, T5, and we are proud of him. But this is a little video I found. I took out the sound because it's like for patients, and so it's literally like, this is a body. But I think that it's good to just have like a visual. And so you're watching the drainage, which is starting on the right side and then crossing over to the left side at, as Joe said, T5, T4, T5, T5 and then emptying into the subclavian IJ junction. And so I don't know, maybe if we look at this video, then we'll be able to just think about it better. So obviously this is just a good anatomy slide and you should just know this stuff for life. This is a slide that I left white because I don't think that I've ever seen this come up in practice questions or on the ABSITE. I don't know if other people have had different experiences, but it is good to go over the segmental anatomy of the lungs. And so obviously we have 3 lobes on the right and 2 lobes on the left. There are 10 segments on the right and 8 segments on the left. And so we can just go through these, but the right upper lobe has apical, posterior, and anterior. The right middle lobe, Nissen used to always say, like, right middle lobe, RML. And so medial and lateral are the two segments for the right middle lobe. And then for the lower lobe, you have this superior, and then you have basically every cardinal direction, but with basal. So anterior, posterior, medial, and lateral. And then on the left side, you have the apico-posterior branch, and then anterior. So it's analogous on the right and the left, in that upper section. But then, of course, you don't have a left middle lobe, you have the lingula, which is the opposite of what it is on the right. So the right is medial and lateral, and the left is superior and inferior. It's not really opposite, right? Because there's also like anterior and posterior, but I don't think there's a better way to think about it. So, and then the lower lobes are analogous with the superior, anterior, medial, and lateral. So, good thing to know. I don't think I've ever seen it actually tested on the ABSITE. I don't know if anyone else has. PFTs occasionally come up on the ABSITE, and so I wanted to go over them. So the first column that we talk about are the volumes, which are just like the standard one section of the graph. And then as we move to the right into capacities, then you're starting to combine volumes to form the different capacities, if that makes sense. So the first one that we talk about, which is this one right here, what is that called? Good. So that's tidal volume. And then do you know what the amount that we can breathe above a tidal volume is? That next volume, which the projector just did that cute little thing it does where it kind of cuts out really quick. So you're thinking the right thing, but we're still on volumes. We're not in capacities yet. So it's inspiratory reserve volume. And then you'll see when we move to capacities, if you combine those two, that's inspiratory capacity. So then it's kind of hard to see on this chart, but then basically this expiratory, yeah, so it's expiratory reserve volume down there. And then the last one, do you know what the last volume is? Exactly, residual volume. And so then if we move over, if we start combining those, your tidal volume plus your inspiratory reserve volume, as Pranav said, is your inspiratory capacity. And then your expiratory reserve volume and your residual volume is your functional residual capacity. And then the big one's obviously your total lung capacity. And then do you know what everything minus the reserve volume is? So, we're talking about your tidal volume, which is like your normal breath, and then your inspiratory reserve volume, which is what you can breathe above that, your expiratory reserve volume, what you can expire below that. And so yes, your vital capacity. Excellent, Dr. Vandekar, that was a really good answer. So these I think are worth going over because I have seen occasionally questions just kind of about labeling those. And then we will talk a little bit about where they kind of come into play with preoperative screening in a little bit. Dr. Nissen had all these flow volume loops in, which I think are really cool, but I don't think that they've ever been asked on the ABSITE, and we don't have a ton of time. So I'm just going to move through them now. This is the normal flow volume curve. Time isn't on here. So it can be kind of a confusing graph to think about, but it's literally just flow and volume. And so when you're expiring, you're rapidly increasing flow until you get to the top of that curve. And that's when your volume is going to be the lowest because you've expired all of your volume. And then your volume starts to creep up as you're inspiring. And that flow as you're inspiring is going to be high at the beginning, and then you'll slow down as you get to the top. Your volume will get really high and your flow will get low, and then it just continues in that loop. And then I do think it's worth just kind of remembering what an obstructive versus a restrictive flow volume curve looks like. So what's this one? Yeah, obstructive. So what are some obstructive pathologies?
You-
Yeah, COPD. And then this is restrictive. And so what are some restrictive? Yeah, yeah, anything that's gonna cause like lung fibrosis. And then also anatomic things like scoliosis and stuff like that can be restrictive, or obesity even. And then he started talking about variable extrathoracic and variable intrathoracic, which we are not going to get into because, again, not going to be on the ABSITE. So what will be on the ABSITE is what to do when you have a patient who presents with a solitary pulmonary nodule. So it's usually going to be like a trauma patient. You scan them and you see this small nodule, and it's like, what do you do next? So there are a bunch of flow charts that you can look at that I think get to be a little bit confusing. And I think that you can answer most of the questions if you think about it like this. So usually if it's a stable, small nodule, aka, so stable meaning if you do have previous imaging and it hasn't changed, then you can either do nothing. Sometimes it's been the same for 20 years and there's nothing else to do. Or you can do re-imaging at some interval, which usually that's enough to get you the answer on the test. If and that's if it looks benign. So you'll see like calcifications that are kind of uh it might be like a popcorn calcifications or something that's not scary appearing. If it is growing, or if it's a little bit more scary in its appearance, then you have to look at the risk profile of the patient. So if they're a low risk patient, like they've never smoked before and they don't have risk factors for lung cancer, then you might just get serial imaging, and you do that at a close interval if this is like a brand new lesion or a lesion that's growing but slowly. If they're an intermediate risk, that's when you would want to think about more, doing more imaging with either a PET CT or thinking about a biopsy. Like if that's going to be pretty low risk and it's say it's like centrally located, then you're going to end up doing like EBIS and biopsying it that way. Whereas if it's peripheral and easy to wedge out, or if the, or the patient's super high risk and you have a high suspicion that this is a cancer, then you're going to want to proceed to the operating room and you'll do a VATS. You'll plan for a wedge resection and wait for the frozen to come back. And if the frozen comes back and it's benign, then you're done. And if the frozen comes back and it's malignant, then you have to do a formal resection so that you get that nodal harvest. And then I already put it up here. So the most common type of lung cancer is non-small cell lung cancer. And under the umbrella of non-small cell lung cancer, it's adenocarcinoma that makes up like 40% of the non-small cell lung cancer. So that is the most common kind of lung cancer. This is a question that I kept on here that we can look at together. So I think that we're going to talk a little bit more about lung cancer treatment and staging, because we're about to get into the nodal stations. And so we'll kind of go over what I think is like the very basic thing that we need to know for the ABSITE. But I kept this question in from Dr. Nissen because I thought that it was a good one. So which of the following is correct regarding surgery for early stage lung cancer? So local recurrence after segmentectomy is equal to lobectomy, lymph node dissection, improved survival for stage 1 tumors. Tumors greater than 3 centimeters in diameter have a reduced survival compared to smaller tumors. And no adjuvant therapy is required for a complete stage 1 tumor following complete resection. The majority of recurrence after stage 1 disease is local. Does anyone have any thoughts? Good, Nat. Yeah, D. So no adjuvant therapy is required for if you get all of a stage 1 tumor out after resection and you know none of your nodes are positive, then that's the treatment. And so I think this question just highlights that for lung cancer, if you have, if you stage it and you don't have metastatic disease and once you get it out, you don't have any nodes, surgery is the mainstay of treatment. And then there were some quick hits on this slide, some of which I, didn't think were necessarily super ABSITE related, but lung cancer is still the most common cause of cancer-related death. Where's the most common site of Mets from lung cancer? Where does lung cancer go? The brain, yeah. This is just like an ABSITE thing. Another place that lung cancer goes that is kind of unique. A lot of times they'll ask it in reverse. So it's the adrenal gland. So if you have an adrenal nodule, then and it appears to be a Met, then lung cancer should be high on your differential. We already talked about the most common cause of cancer being adeno. Small cell cancer, like I was talking before about how, in stage 1 lung cancer, you're generally thinking about cutting it out. But that's the exception to that is small cell cancer, which is very responsive to chemo and radiation. And so for small cell, you're going to do that. I don't know the different carcinoids, so that's why I just clicked through that. Treatment for mesothelioma. Does anyone? I basically left this in because mesothelioma, if you see it on the test, like probably that patient's going to die, and it also in real life. It's so not a pleurodesis. I mean, sometimes you can do a pleurodesis if you're doing like symptomatic control, or I guess, and you're trying to just get rid of like a malignant effusion. But the real answer would be an extrapleural resection. And so you'd want to take out all of the involved tissue essentially, which is incredibly morbid and patients still do really, really poorly. So mesothelioma generally is going to have a pretty poor prognosis. And then this is stuff that always comes up, the different paraneoplastic syndrome. So small cell is associated with ADH and ACTH, and then squamous cell is PTHRP. Do people have ways to remember that? I don't have a good way to remember. If you just know it though, a wise man once told me. Yeah. Okay. This is definitely going to be on the test, or at least it comes up quite often. So when you're doing preoperative decision making, deciding how much lung you can take out or if the patient's going to tolerate the surgery, which of these is the greatest predictor of mortality? Yeah. Yeah. DLCO is the one that is the greatest predictor of mortality, but they'll ask you questions about all of these, or at least it comes up, I think, at least one question. And so generally for FEV1, so the forced expiratory volume in a minute or a second, I'm going to edit that out, should be greater than 60%. And that's just their preoperative FEV1. And then that's separate from the predicted postoperative FEV1, which is based on how much you're going to have to resect with your surgery, which should be, it says greater than 800 mils here. The one down here, I put this one on from TrueLearn because I've seen this come up. So the one down here, post-op predicted FEV1 40%. And then sometimes they'll ask in like liters, which obviously these are not maybe not obvious to everyone, but these numbers, the percentages are based on men generally. And so if you like want to be like correct, then you should really update that. But they talk about 2 liters because that is generally 60% for your average male. For a pneumonectomy, 1.5 might be the 60%, but 2 liters for a pneumonectomy, 1.5 for a lobectomy, and then 800 mils for a wedge resection. So these are just numbers that you should memorize. And then if you're talking about the kind of preoperative workup that you're going to do, generally you're going to start with spirometry and you're just going to use your PFTs. And if those numbers are good and you feel confident that you're within that suggested range, then you can stop there. But if you have borderline numbers, which often in the test, they'll give you something that's borderline and they'll say, what should you do next? And then the next thing would be a quantitative VQ scan, because that's what helps you to see what portion of the lung that's diseased is participating in that gas exchange. And so then if not a lot of it is, then you can safely take out that section of the lung because it's not really contributing to your borderline number anyway. And perhaps your FEV1 might actually be quite similar to your predicted post-op FEV1 if that disease section isn't really contributing much. And then if your VQ scan is still marginal and you want to do more testing, then you can move to cardiopulmonary exercise testing, and that can help give you a little bit of a better idea of how your patient might do. So it's either one, and they'll test you on either. So the DLCO is just better than like FEV1 and those kinds of things for predicting mortality. But whether you do predicted post-op or just DLCO, I believe that it's similar, but I'll have to look that up and verify. I don't think they're going to ask you to pick between those two, though. I think they'll usually just ask you the first question that I showed generally. This is my picture that I made for the lymph node stations. And this is historically something that people get nervous about because it can be very confusing. However, I think that if you look at it and draw it out a little bit, then perhaps it's not quite as confusing. And we'll go over specifically what I think you actually need to know. And so if you move down the trachea, you start at the top with 1, and it's just right and left. 1R and 1L. And then you move down to 2, which is similar to R and 2L. 3 is different because 3 you have posterior and anterior. And that can be important because depending on if your node is posterior or anterior, it may or may not be easily accessible with mediastinoscopy. So when you do mediastinoscopy, has anyone ever done it? Where are you moving? Yeah, where are you moving relative to the trachea, anteriorly or posteriorly? Yeah, so that, a 3P, station 3P is not going to be accessible via mediastinoscopy. So that's where that kind of comes into play. And then 4 again is right and left. And then 5 and 6 are the ones where you're going to have to do like fancy procedures generally. Although with VATS, things have become a lot easier. But historically, that's when we start talking about like the Chamberlain procedures and things like that to access those nodes, which you guys are all familiar with. And so 5 and 6 are the ones that are near the aorta, 5 subaortic and 6 para-aortic. And then 7, we come back to the middle and we're continuing to move down. And now 7 is subcarinal. So 7 are the last ones where historically you can reach with mediastinoscopy. 7 you can also reach with EBUS, which I'll show you in a second is probably, I think, moving forward going to be the answer for most central, and even as we get into like hilar and maybe interlobar,
You know, obviously if the nodes are really peripheral, you can't easily reach that, even with a navigational bronch, sometimes it can be difficult, but we're moving away from these, like talking about mediastinoscopy and these procedures in favor of talking about EBUS and doing VATS biopsy. But if we continue to move down, then moving down the esophagus, 8 is paraesophageal. So we're 1, 2, 3, 4, 5, and 6 are over there, and then back 7, 8, and then 9 is along the inferior pulmonary ligament. And so those are all single digit numbers, and they're all in the mediastinum. And so that's how you remember. The mediastinal ones just move down and they're single digits. As you start to move out into the lungs and get more peripheral, that's when you're talking about double digits. And those move in order from 10 out. And so 10 is hilar, and then 11 is interlobar, 12 is lobar, 13 is segmental, and then 14 is subsegmental. And so this comes into play when you're thinking about your stage, specifically what's your end stage of your lung cancer. And so obviously no nodes is N0, N1. So think about what would be the best case scenario, right? If you have to have a positive node, the best case scenario is that it's right near where your cancer is. And so it's going to be plural. So is it going to be a single digit or a double digit number? Double digit, right? And because you want it to be right next to where you are. So you don't want it to be all the way in the mediastinum if your cancer's out here, which it probably is. So it's going to be a double digit number, and you want it to be ipsilateral. Obviously, if it's on the other side of the lung, that's pretty bad. So N1 means ipsilateral plural. And so you're looking for a double digit number nearby wherever your tumor is. And if you see that, then you can do surgery up front. The next best thing would be still on the same side, ipsilateral, but mediastinal. So now if you have a single digit number, that's worse than a double digit number. It's a little bit further away probably, but if it's still on the same side, surgery may still be an option. So N2 is ipsilateral mediastinal, and you have to do neoadjuvant chemotherapy. And then worst case scenario, or I guess not, we're moving towards that, would be N3 contralateral mediastinal. Then there's a little exception of another thing that can be, and that means N3 disease, like a weird node, a supraclavicular node. So N3 is contralateral mediastinal, so single digit, but on the other side, or supraclavicular, and those patients are not going to be surgical candidates, and they're probably going to get, definitive radiation therapy. And then N4 is if you have contralateral plural, so contralateral double digit, but that probably is, or could be just another primary, it depends, but that's bad. Or met. Does that make sense? So if you know those nodal stations, then that's really what you need to know to decide what to do generally. And I think for the ABSITE that holds true. I don't think that this is all that helpful. That's why it's a white slide. It's from, I don't think they're going to straight up ask you what the lymph node stations are. I think that they more will give you like, there's a mass and there's a node here, and you have to know like how bad is that. And that's where like double digit on the same side, good. Single digit on the same side, getting worse, probably need neoadjuvant. Single digit on the other side, probably not going to be a surgical candidate. Yeah. And so if you want to know the answer to that, that's correct. I do think that this is something that they have asked historically, like where you can access with different modes of sampling the nodes. And so do you remember which one we would say is not accessible by mediastinoscopy? Yeah, so 3. And then this is just in here for, it's kind of
going over what we just talked about. Obviously, this is in more depth, but so this is a little bit more about what you can access with what. And so mediastigmoscopy we talked about would be, you know, those ones that you're going to be able to get to anteriorly along the trachea, and you can get down to 7. However, E-bus is really largely replacing this. And then the Chamberlain procedure is levels 5 and 6, and then VATS. I mean, you can get to most of them with VATS. So I would say that I think that's where the questions are going, and I got this one wrong. Let's see. I guess we can do these first. So, oh, I thought that this was a good thing to kind of think about. But it's a little bit too much information, I think, honestly. But combining PET and CT, I thought was a good thing for us to just remember in general, that does appreciably improve diagnostic accuracy. So that's why I kept this question in here. This question, which of the following is not an indication for mediastinoscopy? This is just another way that they could ask that question. And so, can you reach a station 6 lymph node via mediastinoscopy? No, so that would not be. And then this is a question I did yesterday and got wrong because I was thinking about the older stuff, and I was like, oh, 2 and 7 mediastinoscopy, but they wanted endobronchial ultrasound, which makes sense. I mean, that's what we're using. And so this is just to show that the test, I think, is you know, catching up. And so I would, yeah, 2, 4, 7. Okay. And then, so getting into just some stuff that they always like to ask. So mediastinal tumors. So in adults, what is the most common anterior mediastinal tumor? That's in kids. So in kids, it's lymphoma. In adults, it's going to be a thymoma, is going to be most common. What is in adults and kids the most common posterior mediastinal tumor? Yeah, neurogenic. And then what is it more common to have is it more common to have an anterior or a posterior mediastinal tumor? Anterior, yeah. So the most common site of mediastinal tumors is going to be anterior. But what's the most common overall mediastinal tumor? Is confusing because it's neurogenic. So the most common overall is neurogenic. You're more likely to have one anteriorly, but because that gets split up between all of the T's, thymomas, teratomas, terrible lymphomas, they say, because that gets split up between all the T's, even though it's more common to have a mediastinal tumor anteriorly, the most common mediastinal tumor is actually a neurogenic tumor because that's the only one that's in the posterior area. That can kind of slip people up sometimes. And then when we talk about thymomas, they always mention this on Behind the Knife. I'm not sure I've actually seen a question about this either. Maybe I have to do more questions, but in terms of the relationship between thymomas and myasthenia gravis. So do you remember the little thing they talk about 50% for thymomas? So 50% of thymomas are going to be malignant, 50% are going to be symptomatic, and 50% are going to be associated with myasthenia gravis. So that's a lot. A lot of people who have a thymoma, half are going to have myasthenia gravis, but the inverse of that is not true. So most people who have myasthenia gravis are not going to have a thymoma. So it's only 10% of people with myasthenia actually have a thymoma. But then counterintuitively, if you do thymectomies on people with myasthenia, even if they don't have a thymoma, 80% of people whose thymus you take out are going to have resolution or improvement in their myasthenia. So I think that people like to talk about that because it's interesting, but I don't know if I've really seen a question about that. And then Behind the Knife always mentions post-thymectomy myasthenia crisis. The treatment for that is IVIG or plasmapheresis. Okay, so this is just a question about my mediastinal tumors that I saw in TrueLearn. So they were asking if you see this on a CT scan, that's, you know, just a trauma patient, you see it incidentally, what's your next step in the mat? And it's an imaging thing. It was like CT, MRI, PET, blah, blah, blah. So this is a posterior tumor, right? And so what do you think that it probably is? Neurogenic. So the answer was MRI because it's probably like, if it's benign, it's like a ganglioneuroma or something like that. You want to see the nerve roots it's involved with, or is it the sympathetic chain or what, so that you can decide what to do about it. Okay. This is something else that comes up in the thoracic chapter in the ABSITE, and that is SVC syndrome. So compression or invasion of the SVC from something, right? So it can be a mass like this is showing in this picture, but this can be something else too, right? It can just be like diffuse lymphadenopathy if someone has lymphoma and not necessarily just one big mass, or it could be TB. This is where we could get you know, stenosis from having a catheter long term. And that can cause SVC syndrome. So what's the treatment for SVC syndrome? True. So we talk about if it is like cancer or something like that, this is when we talk about emergent radiation, not necessarily surgery, because a lot of these, you know, it's not curative with surgery. So you'll do radiation. They can be pretty responsive to radiation. But even if they're not caused by a tumor, there's some, you know, treatment options, and people talk about steroids and then anticoagulation if it's needed. Oh, really? Oh, interesting. Christina, she may have ulterior motives, is saying that we can stent these, and we've moved away from doing emergent radiation. So we'll have to fact check that. And then obviously, you know, pathognomically on the ABSITE, when we talk about SVC syndrome, we're talking about a Pancoast tumor. And so what kind of cancer is usually a Pancoast tumor? So think about, like, we just talked about, which Christina proved me wrong, but we talked about doing radiation. Oh, actually, don't think about that. It's non-small cell. Sorry, you're right. It's adenocarcinoma. So non-small cell lung cancer, and it's usually located at the thoracic inlet. And then, if it's really advanced, that's when we talk about doing chemo radiation. But you're right. What was I going to say about this slide? Oh, so what is another presentation that you can look for with Pancoast tumor? Yeah, so what's Horner syndrome? Yeah. Yep. Ipsilateral meiosis, ptosis, and anhidrosis, right? So droopy eyelid, constricted pupil, and lack of sweating on that side. And it's ipsilateral. Good. So this was just a question about lung abscesses. I don't know that this specifically would be tested, but it was talking about how sepsis and empyema are usually the result of that abscess rupturing into the pleural space. I think that it's an interesting thing because it kind of lends to how we treat these, right? So what is our usual mainstay of treatment for a lung abscess? What's our first thing that we're going to do? Yeah, antibiotics, exactly. Which, like, is different, right? It's different from other places in the body, where if we have abscesses elsewhere, what do we do? Right. So that's why I'm pointing that out, is because that, you know, we're not talking about draining these abscesses necessarily. Now, if it is complex complicated or has a thick wall or something like that, then sometimes you can think about drainage, which a lot of times will be via bronchoscopy, like getting in there and trying to get into the abscess and suck some of that stuff out. And then this is talking about the reasons why. Oh, this is just more about how medical therapy is the mainstay of treatment. People get lung abscesses because of aspiration events or poor dental hygiene a lot of times. We already talked about antibiotics and whether or not we're gonna bronch. And then if you have like a very persistent abscess, a persistent area of the lung that's consistently, you know, creating pus and becoming a problem, or if it's really big, they say greater than 4 centimeters in size, or if there's a really thick wall, that's when you can consider surgical intervention for these. Usually though, that I don't think that that's going to be the answer on the test. Usually it's going to be antibiotics. And what antibiotics are you going to use? Yeah, so you'll use Unison, ampicillin, sulbactam. And I had a question yesterday about a patient who had a beta-lactam allergy. And so the answer was levoflagell. But yeah.
You drain it and then rescan, see if there's cancer there.
Yeah, I mean, I think that a biopsy at the time of drainage is probably a good idea too. Yeah. Okay. Guess what we're gonna talk about now? We're talking about spontaneous pneumothoraces. So this is just a stock image I found of the, typical kind of patient you may see who comes in with a spontaneous pneumothorax.
I wish there were more.
Me too. They'll watch online, don't worry. This is funny because Pranav's the only resident at this lecture, so it's like it was tailored for him. Okay, so the difference between primary and secondary spontaneous pneumothoraces. Spencer's here too, but he doesn't count. Forgot to staff with Dr. Masella, she's calling me. So the difference between primary and secondary spontaneous pneumothoraces. So primary is the ones that we typically think of, right? That are from blebs. We think of these tall boys, really lanky, who grow quickly and they form these blebs that burst. Secondary spontaneous pneumothoraces are spontaneous, meaning that they're not because of trauma or something sharp cutting into your lung, but it's because of a pathology that is existing in your lung. So people with COPD or, bad lung fibrosis will get secondary spontaneous pneumothoraces. And so it's important to know the kind of algorithm for how to treat these. So if someone comes in with a really small pneumothorax, they had some chest pain, it's better now, and you can really barely see it on chest x-ray and their vitals are fine. What are you gonna do? Yeah, you can just you can put O2 on them. I don't really think that makes a difference, but you just watch them, get a repeat chest x-ray and make sure that it looks better, and then they can go home. What if it's like a really big pneumothorax, but their vitals are still fine, but it's like 50% of the lung is down? No, at that point, if it's like 50%, you should do something. Yeah. And so what I would do is probably a pigtail at that point. If that space is really that big, and just do like a small tube. Some of the answers talk about aspirating. I would just put a pigtail in if you're, sticking it in the chest and then you're hoping that in the next day you'll be able to pull it. I think it's worth just putting a pigtail in. But if in the right clinical scenario, the answer on the test could be aspiration. And then obviously if someone has tension physiology, you're gonna put in a chest tube, which behind the knife still mentions needle decompression. If it's like the only answer choice that makes sense, sure, but obviously we're just gonna put a chest tube in. Finger thoracostomy. And then when do you operate on these people? for someone who has spontaneous pneumothorax, what are the indications to go to the OR with them? You can just put a chest tube in if they're hemodynamically unstable, and if it's their very first time that this happened to them and the pneumo gets better and their chest tube gets pulled and they do fine, you don't necessarily need to operate on them. So the reasons you operate is if it's recurrent. So if this has happened before and this is their second time, interestingly, even if it's recurrent on the other side, so if they've had a right-sided pneumo before, now they're coming in with a left, that's still an indication to go to the operating room. And so if it's recurrent, if they have a high risk profession, people talk about that. So if they're like a scuba diver or a pilot or something like that, then you might consider moving to operate. Or if you put the chest tube in and they have a persistent air leak, then obviously you're going to need to do an operation. Potentially way down the road, you're going to manage your persistent air leak, as is appropriate, which sometimes is chest tube for a long time, but that is usually an indication to at some point do a surgery. So what's the operation that you do for primary spontaneous pneumothorax? So you're going to do a VATS and a blebectomy. And so usually you go in, you look at the lung, you can see the blebs. Where are they usually located? Apically. What if you get in and you don't see any blebs? What do you do? No, you do. Traditionally, they teach doing an apical wedge resection. So you're thinking that there are probably blebs there that you're just not seeing. And so you take a wedge resection at the apex because you're there and you've decided this person needs an operation. And so you're assuming that there are blebs somewhere that you're just not appreciating. And they're probably in the apex. And then what else do you do in that surgery after you do your blebectomy? Yeah, that is true, but it shouldn't. There is an answer, and it's a pleurodesis. There are different kinds of pleurodeses. Yeah. So a mechanical pleurodesis with a Bovie scratch pad is most commonly utilized. Okay. We'll move on here. This is a question about the lights criteria. So she has a thoracentesis for this effusion, and her pleural to serum protein ratio is 0.7. There are malignant cells on cytology. Is this transidative or exudative? Good, exudative. So anytime there are cells, it is exudative. And so that is, I think, the most straightforward, easiest way to think about this. The exudative effusion is coming from something that's disrupting that capillary membrane and letting cells out of the bloodstream into the pleural space. And so exudative is going to be a parapneumonic effusion. I think that's the one that people get tripped up on and think that it's transidative. But just think about sepsis. Sepsis leads to leaky capillaries, and you're going to have cells leak out. And so that's going to be exudative. And then cancer, because there's malignant cells. So even without the memorizing the lights criteria, you could have told me that that was exudative just because they said that there were cells in there, right? Whereas transidative is going to be because of either low oncotic pressure or high hydrostatic pressure, and it's just going to be fluid leaking across the membrane. And then if you think of it that way, then you can figure out what it is without necessarily memorizing these things, right? Because like if there's a high protein content higher than your blood, then it's probably exudative. If there's a lot of LDH, then it's probably exudative. We'll talk a little bit about empyema. Dr. Nissen wrote about the different stages of empyema. I think that the important thing is that stage 2, the fibrinopurulent stage, is really when you ideally want to intervene and put a chest tube in. And then this is a little bottom line from TrueLearn about the indications for drainage. So if they're really big, if they're loculated, if they are really acidic, if you know that there are organisms in there, or if you aspirate frank pus. That was the question I got yesterday, which seemed pretty obvious, but hopefully you guys get that one on the ABSITE. Okay, so what if you have a non-infected patient who has an effusion and you see fluid that looks like this when you tap it? What do you think this is? Yeah, chyle. So this is a chylothorax. How does this happen? Sure, yeah, direct trauma to the thoracic duct. That can be from something you do in the operating room. It can also be like invasion from a malignancy, or sometimes they can even really be idiopathic. But yeah, I think that's what I meant to say. So what is a treatment? So if you have a chylothorax, it's appropriately drained with a chest tube and it's putting out about 200 a day. What's going to be your treatment for that? Exactly. So you're going to start the patient on NPO with TPN, and you're going to supplement with medium chain fatty acids. And then this works in most patients, especially if it's like fairly low output like that. If it doesn't work, what's the next thing that you think about? You can give octreotide. Sure, that hasn't worked that well in my experience, but that is the answer, yes. Usually the octreotide kind of goes with the NPO TPN thing, I think. Yeah, and then you can talk about IR embolization, or you can do a surgical embolization or surgical ligation of the thoracic duct. This was just a question I thought was relevant in the thoracic scene because we'll see a lot of METs to the lungs. And so for metatestectomy, the selection criteria, you can take out multiple extrathoracic METs, which we know. But these other things you need to have. You need to be able to completely resect everything. You need to have local control of the primary, and they need to be able to tolerate whatever you're going to do. Then we get into some trauma stuff, which I think we are pretty well versed in here at Brooke Army Medical Center. But motor vehicle accidents are the main cause of blunt tracheobronchial tree injuries. I think this is always helpful to review, just like where you would make your incisions. So, obviously if it's above the clavicles, you can make a cervical incision. And then certain things you need to make a median sternotomy and then a right and left thoracotomy. So you should review all of those different things, which we won't have time to go through right now. No, I mean, you mean from this question here, like local control? No, basically like, because you can do resections of METs at the time of surgery too. And so at that point you're saying, well, I haven't really taken it out yet, but if it's small enough and you think you're going to be able to remove it and you have a low suspicion that there's like going to be heavy nodal disease on the other side of the chest or things like that. That's basically what they mean. Yeah. And then there was a question also about how to do a pericardial window, where to make your incision. And so that's another good thing to review. And then I think we'll stop for now because I have to go to the OR. But I left some other questions in here. And then I left some stuff about cardiac surgery as well that you can go over if you want. But I think that it's pretty unlikely to be on the ABSITE. I have not seen a lot of cardiac on the ABSITE. The one thing is that sometimes they'll ask about patency rate of the different cabbage grafts, and so obviously Lima has the highest patency rate, and then you can talk about the radial artery, which people rarely do because the saphenous is so much easier and less morbid to get and has pretty good patency rates. Okay, thank you.